Hi, my name is Philippe Moreau. I'm working at the University Hospital of Nantes in France. My topic of interest is multiple myeloma, and I would like to share with you some data regarding the use of anti-CD38 antibodies in the management of patients with multiple myeloma. You know that CD38 is an antigen that is always expressed on the tumor cells, on myeloma cells within the bone marrow. And CD38 has also very few expression on normal tissues. So that's a very interesting target because you can target the tumor cell and you're not targeting other tissues and you're not inducing a lot of toxicity outside of the bone marrow. And we currently have two antibodies, two CD38 antibodies that are approved, both by FDA, by EMA, and by many countries, in fact, worldwide. The first one is daratumumab, and that's a fully human antibody. And the second one is isatuximab, that is a chimeric antibody. The epitope on CD38 that these two antibodies are targeting are different. The affinity to the antigen is also slightly different, but at the end of the day, there is very few difference when you're looking at the safety profile and that the efficacy of both CD38 antibodies. The mechanism of action is very well known. In fact, there is some direct effects. The antibody is able to target CD38 and to induce directly apoptosis, but also cell death may be induced by ADCP, ADCC, or CDC as well. We know that there are also very important immunomodulatory effects, and daratumumab and isatuximab are also able to recruit some T cells that are very important, in fact, for the killing of the myeloma cells and to induce apoptosis. Those two antibodies have been developed in very advanced patients first, a long time ago, in fact, more than 10 years ago. But now we are using these antibodies, daratumumab and isatuximab, as part of frontline treatment as well, in combination with other agents. And if you're looking, for example, at the European EHA and ESMO guidelines, we have different options that are proposed for patients that are not eligible for autologous stem cell transplantation, elderly patients above the age of 70 or 75. And you see that in the first options that we are proposing, and the same is true in the US, in fact, daratumumab is proposed in combination with Lendex, the DRD combination, but daratumumab is also can potentially be proposed in combination with bortezomib, melphalan, and prednisone, the dara-VMP regimen. When you are looking at dara-VMP, the Alcione study compared prospectively VMP versus dara-VMP, followed by daratumumab maintenance in a phase 3 study, the Alcione study, and the progression-free survival was in favor of the combination, including daratumumab, and there was also an overall survival benefit. I know that at the end of the day, this combination, dara-VMP, is not widely used, especially in the US. I know that our US colleagues are very rarely using this combo because we have another combination that is really more active and with better results. And this is the DRD combination, the combination of daratumumab, lenalidomide, and dexamethasone, that was tested in the randomized phase 3 study, the MAIA study, in patients not eligible for autologous stem cell transplantation. And the primary endpoint was progression-free survival with a number of secondary endpoints, especially overall survival, for example. When you are looking at the update analysis of MAIA with now a very long follow-up, there is a clear benefit for progression-free survival with DRD versus Lendex. And you see that median PFS is 62 months, more than 5 years. And those results are the best ever reported, in fact, in transplant-ineligible patients. And this benefit for PFS translated as well into overall survival benefit. And you see these incredible results, the best again ever reported for elderly patients with DRD. So DRD is approved, is widely used in Europe, in the US as well, and is probably the first choice currently for patients that are not eligible for autologous stem cell transplantation frontline. We have some subgroup analysis of MAIA that are also very interesting. And if you are looking at the outcome for patients that are less than 75 years of age or less than 70 years of age as well, you see the huge benefit of DRD, and the results are really amazing for PFS, but also for overall survival with incredible 80% of overall survival in patients less than 70 years at 5 years. When we are looking at frail patients, because some frail patients could be enrolled into the MAIA study, there is also a clear benefit of DRD that is feasible in frail patients versus Lendex alone. Obviously, when looking at the two subgroups of patients with DRD, frail and non-frail, the non-frail patient population has a better outcome, but nevertheless, DRD is feasible in frail patients. We can also look at some interesting subgroups, such as patients with poor cytogenetics. And when patients have either no, zero, or only one cytogenetic abnormality, the outcome with DRD is very, very good. But for patients with 2 or more cytogenetic abnormalities, you see that there is really a decrease in the progression-free survival benefit. And this subgroup of patients with what we are calling ultra high risk, with 2 or more cytogenetic abnormalities, this small subgroup of patients, 20% or less of the cases of patients with multiple myeloma, are really in the unmet need, and we need to try to improve their outcome. CD38 antibodies are also tested as part of frontline treatment for patients that are eligible for autologous stem cell transplantation, especially during the induction phase, in fact, before stem cell transplantation. And you see that we have prospectively compared a triplet combination both before and after stem cell transplantation versus a quadruplet, including daratumumab. We tested bortezomib, thalidomide index, VTD, plus or minus daratumumab. And definitely the response rate and the primary endpoint of the study was stringent CR before maintenance. The response rate was really highly increased with the quadruplet combination. The addition of dara improved the depth of response. It also improved the rate of minimal residual disease negativity, 64% before maintenance with dara versus 44% only with VTD alone. And this depth of response translated into a better progression-free survival. And based on these results, the VTD dara regimen was approved by EMA and FDA in the setting of stem cell transplantation. The follow-up is short, but there is already a trend for a better overall survival with the quadruplet combination. Daratumumab was also tested in the randomized fashion as part of maintenance versus no maintenance versus observation. And daratumumab is improving the outcome of patients during the maintenance phase, but there is a strong interaction of daratumumab proposed during induction and during maintenance, and the benefit of daratumumab is mostly observed for those patients who did receive dara upfront. So quadruplet combinations are now proposed more frequently for younger patients before high-dose melphalan? And why not using dara-VRd with lenalidomide instead of thalidomide? And the Griffin study, a phase 2 trial that did enroll patients in 35 centers in the US on 200 patients, also tested VRd versus VRd plus daratumumab, both before and after stem cell transplantation. And the depth of response is also highly improved, increased in the DARA arm of the study, and the rate of MRD negativity as well is much higher with the quadruplet combination. And again, same story. The depth of response translated into a better progression-free survival. And we believe that, although not yet approved, dara-VRd will probably become, in the future, one of the standard of care for young patients before stem cell transplantation. Isatuximab was also tested, in fact, in combination with VRd. And the German group tested VRd before stem cell transplantation versus VRd plus isatuximab. And the paper was published last year. You see that induction, VRd alone or VRd plus isatuximab before stem cell transplantation, and the early results are really showing that the response rate and also the rate of MRD negativity at 10 to the minus 5, that is the official threshold for MRD negativity, is really in favor, in blue, of the arm with isatuximab. We need to wait, in fact, for a longer follow-up for progression-free survival data into the study, but nevertheless, very promising results with this quadruplet, including isatuximab. Isatuximab has also been tested with carfilzomib, lenalidomide, and dex, the KRD isatuximab combination, before a tandem stem cell transplantation in this concept study from Germany in patients with high-risk disease. This is one of the only study, phase 2, focusing on high-risk patients. And the rate of response with this quadruplet combination with ISA and carfilzomib is really impressive. All patients did respond, and the MRD negativity rate is 60%. So very promising results with this KRD isatuximab quadruplet combo that is not officially approved by the authorities. And the progression-free survival, these are early data with a short median follow-up. The median PFS is also very promising for this very difficult subgroup of patients to treat. What about relapse? And in fact, the CD38 antibodies have been tested first in the relapse setting. And we know at the time of the first relapse, for example, when looking at the International Myeloma Working Group guidelines, that we have to treat patients according to one very important question. Is my patient refractory, yes or no, to lenalidomide? And when patients are refractory to lenalidomide, we have different options that are preferred for those patients. And in fact, dara-KD or isatuximab-KD are two very important options. We know that with dara-VD, the progression-free survival versus VD alone in the CASTOR study is in favor of the triplet. But for len refractory patients, the outcome is not that good, suggesting that dara plus bortezomib is suboptimal at the time of the first relapse for len refractory patients. So we should try, in fact, to use carfilzomib instead, and that was the design of the IKEMA study that looked in the relapse setting, patients with 1 to 3 prior lines of treatment at carfilzomib dex, one of the standard of care, versus carfilzomib dex plus isatuximab. And isatuximab was proposed IV, 10 milligrams per kg on day 1, 8, 15, 22 during cycle 1, and subsequently every 2 weeks. The primary endpoint was progression-free survival, and you see that in that study, 1/3 of the patients were lenalidomide refractory. And that's very interesting to see that the progression-free survival is highly improved when we are using the triplet combination with isatuximab plus Carfildex, and this median PFS of almost 3 years, 35.7 months, is the best ever reported when we are combining a proteasome inhibitor and a CD38 antibody. And especially for those patients with a prior IMiD treatment, yes, and those patients refractory to lenalidomide, the hazard ratio for PFS is in favor of ISA-KD. So that's why we are considering that Carfildex plus a CD38 antibody is probably one of the best options for len refractory patients. Daratumumab was also combined with carfilzomib dex in the CANDOR study. That's a randomized phase 3 study. The primary endpoint was progression-free survival as well, and very similar results and very similar patient population. In fact, 1/3 of the patients were lenalidomide refractory, and with this update analysis published last year in the Lancet Oncology, you see that the median PFS is in favor of KD plus daratumumab, 28.6 months versus 15 months only with KD alone. So definitely, CD38 antibodies combinations are now the backbone of the treatment of patients at the time of the relapse. And this is especially true for len refractory patients. But some patients at the time of the first relapse are not refractory to lenalidomide. They are either len sensitive, they received previously lenalidomide and they did respond to len, or they are lenalidomide naive. They never received a frontline treatment with len. And in this setting, the international guidelines are proposing DRD, lenalidomide dex plus daratumumab, as the best option. And this is based on the POLLUX study. And you see that the progression-free survival is really amazing, almost 4 years with len-dex plus daratumumab versus len-dex alone. And this is true as well for patients len-sensitive, patients with a prior lenalidomide exposure. The median PFS with DRD is above 3 years. And this, with a longer follow-up, translated as well into an overall survival benefit, as published recently in the Journal of Clinical Oncology. DRD is improving overall survival in relapse patients versus len-dex alone. So that's a very, very important finding for our patients for sure. We know that all patients are going to relapse, in fact, once and subsequently second or higher relapse. And CD38 antibodies, both isatuximab and daratumumab, are used for those patients with a second or higher relapse. We discussed the combination with carfilzomib, with IKEMA and CANDOR, the KD-DARA, KD-isatuximab results in favor of the triplet combination versus KD alone. But we can also use pomalidomide as a backbone, PomDex, in patients with second or higher relapse. And then we can combine PomDex easily with a CD38 antibody, and that was the goal of 2 important trials, randomized phase 3 trials, IKAYA and Apollo. The IKAYA trial used isatuximab in combination with PomDex for patients with at least 2 prior lines of treatment, and the progression-free survival was progression-free. The primary endpoint was PFS. You see that this patient population was very advanced, in fact, and more than 90% of the patients were lenalidomide refractory, and more than 70% of the patients were refractory to both a proteasome inhibitor and an IMiD. And in fact, when looking at the PFS data, the triplet with isatuximab is improving PFS 11.5 months versus 6.5 with a hazard ratio of 0.6. So that's a 40% reduction in the risk of death of progression with isatuximab PomDex versus Pomdex alone. And now we have a long follow-up of this ICAIA trial showing a progression-free survival to benefit and a trend for a better overall survival as well, as published last year in the Lancet Oncology. Apollo looked at Pomdex versus Pomdex plus daratumumab. And interestingly, daratumumab was proposed sub-Q and not IV in this important trial, and primary endpoint PFS as well. So very similar design and very similar results, in fact, in favor of the triplet combination PD-DARA versus PD alone. Median PFS 12 months versus 7 for PD alone. So we can use, and those two combinations, PD-DARA, PD isatuximab, are approved by FDA, and we can use them for patients with at least 2 lines of treatment. I briefly spoke about the sub-Q administration of daratumumab, and this is based on the Columba study. First of all, DARA was tested more than 10 years ago IV, but we thought that it could be possible to use this monoclonal antibody sub-Q. So we needed a study comparing IV and sub-Q, and Columba is a phase 3 non-inferiority study, and we have compared the usual optimal dose of DARA, 16 milligrams per kg, versus a fixed dose of DARA sub-Q, 1800 milligram for patients with relapse multiple myeloma. And at the end of the day, the response rate are really very, very similar. And DARA sub-Q induced single agent, 41% of response versus 37% for DARA IV. So there is no reduction in the efficacy in terms of overall response rate. And when looking at this co-primary endpoint, the C trough of the concentration of DARA IV and DARA sub-Q, there was also no significant difference. Sub-Q is also associated with the same efficacy for PFS and OS versus IV. Obviously, sub-Q is much more convenient for the patients and for the staff, medical staff as well. So now we are using for all patients DARA sub-Q systematically, and the infusion-related reactions are less important with the sub-Q formulation for daratumumab. So we see those changes over time from DARA IV to DARA sub-Q, and we are combining DARA sub-Q with lenalidomide, with pomalidomide, with carfilzomib in different combinations. And recently, we also have tested isatuximab sub-Q, and there is a special on-body delivery system for the administration of isatuximab. That is a very simple one, very convenient as well. And currently, there is a phase 3 study looking at isatuximab sub-Q versus IV, and probably in the near future, the two antibodies will be used in routine sub-Q. That is, again, very convenient for the patients. So I would like to thank you for listening to my presentation, and you see that CD38 antibodies are now combined with all classes of agents, PIs, IMiDs, and they are, of course, improving the outcome of our patients in the daily practice.
You were talking about sort of the biology of CD38, and you were mentioning that there's only CD38 on the myeloma cells, but I thought I saw on your graphic there, is there CD38 on T cells also?
Yes, in fact, on some T cells, and CD38 is able to target these T cells and to activate a subpopulation of T cells that will induce apoptosis. We know as well that CD38 is expressed on some endothelial cells, and and when we tested first CD38 antibodies, we were fearing liver toxicity, for example, or a cardiac toxicity. But the expression is very, very low. And at the end of the day, there was no toxicity extra outside the bone marrow, or very, very few indeed. So that was good news. We started to use daratumumab, for example, at very, 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 very low dose. It was 0.1 milligram per kg. And then we escalated very, very slowly because we were fearing this toxicity. And at the end of the day, no specific toxicity on other tissues such as the liver, the blood, the heart, or the brain as well.
So another a question I had was, has CD38 been looked at as a target for CAR T, antibody drug conjugates, bispecifics?
In fact, yeah, that's very interesting, to try to combine CD38 antibodies with other agents that are very active. And for example, there is an antigen that is now the target of choice for immunotherapy, such as BCMA. BCMA is also always expressed on the tumor cells. BCMA for B-cell maturation antigen. And BCMA is the target of choice for CAR T cell therapy, but also we have now some bispecific antibodies that are approved, teclistamab and elranatamab, approved by FDA, targeting BCMA. And we have now early data, short follow-up, few patients, of the combination, for example, of bispecific antibodies plus daratumumab with a huge activity. Bispecific alone for advanced patients, very advanced patients, the response rate is 60%. And if you are adding daratumumab, you are increasing the efficacy up to 80% of response in patients that are in the unmet need. So very promising results, but we don't have phase 3 data, and the combinations of bispecific plus CD38 antibodies are not approved yet by the authorities.
So another question I had related to the sub-Q issue, the isatuximab sub-Q, can that potentially be done by a patient themselves?
Well, currently, no, because this isatuximab sub-Q study is ongoing, and ISA sub-Q is not yet available outside this clinical study. So we need to wait for an official approval. But in the future, why not thinking of using this system in the outpatient setting and maybe home administration? But we need to wait. That's really too early now.
Yeah, because the device, it looks like it's sort of, easy to use, like almost easier than a syringe and a needle. And
Exactly.
there are I've seen other devices like that.
The device is very, very simple. That's for sure. Yeah.
And so, but just to clarify, when you give sub-Q, how would you compare the experience from the patient point of view of sub-Q Dara versus this sub-Q ISA device? Is it similar?
When asking to the patients, what about quality of life? And some of them did experience IV and subsequently sub-Q. They are really preferring the sub-Q administration. The local reactions are very, very rare, and very few local reactions. Infusion-related reactions as well decreased with sub-Q. So the convenience is good. The patient's choice as well is in favor of sub-Q, definitely.